This is Jose Merino, Editor-in-Chief of the Neurology family of journals. The Neurology podcast provides practical information to neurologists and other clinicians to help them provide better care for their patients. Thanks for listening and have a great week.
Hello, this is Kait Nevel, and today I'm interviewing Elizabeth Gerstner, an Associate Professor of Neurology at Massachusetts General Hospital, on her recently published paper in the New England Journal of Medicine titled Intraventricular CARv3-TEAM-E T cells in recurrent glioblastoma. Elizabeth, it's such a pleasure to have you here today and to be talking to you about your paper.
Well, thank you so much for having me.
I'm looking forward to discussing the details of your paper, but before we do, what is the single most important thing that you want readers and listeners to take away after reading this article or listening to this podcast?
Well, I think CAR-T, or chimeric antigen receptor technology, really has revolutionized the treatment of hematological malignancies and is finally starting to show promise for solid tumors. Tumor heterogeneity has been the biggest obstacle to successful treatment of solid tumors. So the fact that we saw no significant toxicities and this early decrease in contrast enhancement suggests that something is happening in the tumor microenvironment. We're still very, very early in this discovery process and need to better understand what we are seeing in patients. And as we better understand what is happening in patients, this will hopefully increase durability of responses. But I think really the primary take-home point is that we've really just shown proof of principle, which is really the first important step to identifying effective therapies for glioblastoma.
Can you give the relevant background information about glioblastoma and the basics of CAR-T cells?
Glioblastoma is the most aggressive form of primary brain cancer, and unfortunately it remains fatal despite our current available therapies, which really includes treatment with surgery, radiation, and chemotherapy, which typically is something like temozolomide or lomustine and sometimes bevacizumab. And so we've really made very little advances in the treatment of this disease, despite actually learning more about some of the molecular changes or potential molecular drivers in glioblastoma. And so CAR-Ts offers a novel approach to fighting this really challenging disease. And the basic idea behind using CAR-Ts is we take a person's own T cells out of their body via a process called leukapheresis. And then those T cells are sent off to the lab and they're genetically modified in the lab to attack a patient's own tumor. And so typically it's targeting a known antigen or a known target in a patient's tumor. And then those T cells are re-injected into the patient, either intravenously or intraventricularly, like we did in the study, as a way of then targeting and attacking the tumor directly, and also waking up the immune system to get the immune system to target the tumor. One of the big challenges in many of solid tumors is that the immune microenvironment is turned off. It's not a very immune active environment. These tumors are very good at shutting off the immune system, so they are not targeted by the immune system. And so the idea behind CAR-T cells is that we can turn on and activate the immune system to really target and help us fight these challenging cancers.
Can you walk us through the enrollment and treatment protocol used, and what was unique about the CAR-T cells used in this study?
So this was a construct that was developed by Brian Choi, who is a neurosurgeon at MGH when he was working in Marcella Mauss's lab. And what's unique about it is it's sort of a 2-in-1 engineered T cell. So it contains both a CAR, that engineered T cell that targets a specific oncogenic variant in glioblastoma, which is called the epidermal growth factor receptor, EGFR-V3 variant. And that is expressed in a subset of GBM patients. And so in this way, it's almost like we're using that as an active homing agent. So the T cell homes to those V3 mutated cancer cells, but at the same time, it also secretes a second bioactive agent, which is a T cell engaging antibody molecule, or TEAM. And that TEAM was engineered to attack more broadly the wild type EGFR receptor. And so most of GBMs, 40 to 60% of GBMs have this EGFR wild type expression. And so by secreting this TEAM into the tumor microenvironment, even unmodified T cells within a patient's tumor, so their own native T cells that are in that GBM microenvironment, or even some of the cells we think in the circulation, can then also be sensitized against EGFR as well as other local antigens within the tumor microenvironment and convert those T cells into cytotoxic killers. And so it causes this, hopefully, epitope spreading or antigen spreading. So we just turn on that local immune response within the tumor. And so the way we designed the trial to test this construct was, and what we initially published in the paper was our cohort that was the safety run-in cohort. So the first 3 patients that we treated. And so patients had to have a glioblastoma at first recurrence and be candidate for additional surgery. We wanted to do that additional surgery, one, because we wanted to verify that patients still expressed our target antigen of the CAR, so that EGFR V3 as well as EGFR amplification. And at the time of the surgery, they also had a placement of an omyocatheter, which is placed into the ventricular system, and that was used to deliver both the T cells as well as to sample CSF longitudinally over time. And so patients also have to have residual disease because we really felt strongly that there needed to be expression of the target antigens for the CAR T to work. And we really chose intraventricular administration because we really wanted to bypass that blood-brain barrier and ideally, hopefully, get better penetration of the CAR T into brain parenchyma itself, as opposed to intraventricular delivery, where there's some concern about how well it can get into the brain itself.
What were the outcomes of the 3 patients in your publication, and how does this compare to historical outcomes for patients with recurrent glioblastoma?
So in the paper, we report that 2 out of the 3 patients had disease recurrence, unfortunately, only about 1 to 3 months after initial treatment. So the responses were not as durable as we would have liked. However, you look at other studies on recurrent GBM patients, such as, for example, the BLOB study, which was a large European trial that randomized recurrent GBM patients to bevacizumab, lomustine, or a combination, so some of our most commonly used therapies at time of recurrence. The median progression-free survival in that study was only about 1 to 4 months. And so it seems to be somewhat similar to our study. But to be honest, I think looking at outcomes in our study is really way too early. We only enrolled 3 patients, and so our goal was really a proof of principle study to really show that we can safely deliver this novel T-cell construct interventricularly to patients without causing more harm than good. And so since we didn't see any significant toxicities, we are encouraged by this very early study that there could be a path forward for this construct in helping patients with recurrent glioblastoma.
Along that same line of thought, the monitoring patients and treatment responses were interesting and showed some really intriguing results. Could you discuss some of the imaging responses and liquid biopsy methods and results from your study?
Some of the more interesting responses that we saw was that sort of really early decrease in contrast enhancement that all 3 patients had. So within 2 to 4 days of that initial intraventricular infusion, we got a brain MRI to see what was going on. And all 3 patients, there was a remarkable decrease in contrast enhancement, which is just not something that we see in glioblastoma treatment, except for in the setting of something like bevacizumab, which is an anti-angiogenic agent and can affect the permeability of the blood-brain barrier. So in that case, we do see decrease in contrast enhancement, but the mechanism it would not be the same thing that we're seeing here because the T cells don't have that impact on affecting the permeability of the blood-brain barrier. So we don't fully understand what is going on and what's causing that decrease in contrast enhancement so early after the treatment with the CAR T cells. Presumably, it's some impact on the tumor microenvironment. So we're really curious to see if we can figure out other ways of trying to understand what is happening on the tumor microenvironment level. You know, the biggest challenge we face in brain tumor patients is it's hard to get repeated tissue sampling to sort of look and see what is happening within the tumor microenvironment. So the additional assay that we did to try to understand what was happening was to look at liquid biopsies, looking at CSF and blood samples to look at extracellular vesicle RNA. And so these EVs, or extracellular vesicles, are thought to be shed by tumor cells into the CSF and into blood. And so we look at RNA that is found in these EVs, both pre and post treatment. There's some thought that maybe CSF may be more informative in brain tumor patients, and this is where having that Ommaya placement was very useful and convenient for CSF sampling in our patients. No patient wants to undergo serial lumbar punctures to get CSF sampling. And sometimes I wonder if I could put an Ommaya in all my patients to see what's going on in their brain, but that's probably not feasible. But so we had this blood and CSF longitudinally in our patients, and we were able to look at what was happening in the target antigens, so in the EGFR and the EGFR3 alterations, and measure them through these EVs that we were measuring. And what we found is that there was a decrease in both EGFR and EGFR-V3 in all of the patients who were treated on the trial. We were also able to track the CAR-T cells in the CSF, and we found that we could detect them in the CSF up until about 4 weeks, and then we weren't able to detect them as much after 4 weeks. And so the concern is that we're not having durability of those CAR-Ts in the CSF. And so one of our approaches and next steps will be how to figure out how to improve that durability of and persistence of CAR-Ts in the CSF.
What comes next for CAR-T cells in patients with glioblastoma? How does this study inform future study and potential uses?
One of our biggest obstacles and challenges is how to make this response more durable. We know that it is safe, but we want to make it more durable. So we have opened up 2 new cohorts on our trial, and similar to the first 3 patients in the new cohorts, we'll have to have GBM at first recurrence and be candidates for additional surgery. And a cohort will enroll patients with that EGFR-V3 plus EGFR amplification, but we're also going to have a cohort of just EGFR amplification without the V3 because we think this construct works in both scenarios. And so we're hoping with this larger cohort that we'll be able to better optimize this treatment and better understand how we can make it work better. We're adding in lymphodepleting chemotherapy, which is commonly used with other CAR-Ts. And basically the idea behind that is that you give high doses or relatively high doses of chemotherapy, and it wipes out the native T cells that the patient has. And so when you re-inject those engineered T cells, they have lots of room to expand and to grow and take over the system so that they can then target the tumor. So that's one approach we're taking next in terms of trying to optimize this treatment. And then Dr. Choi and I talk about this a lot, about what other targets can we attack in either glioblastoma. Not every glioblastoma express EGFR. And so we're looking into other targets that we can engineer T cells to attack. And you can think about other primary brain tumors like IDH mutant brain tumors. So I think now that we've shown this proof of principle, there's a lot of opportunity for designing these new constructs to attack brain tumors.
A few questions that come to my mind when you mention different targets is going back to the results of some of the liquid biopsy assessments and the decrease in EGFR copy number you saw in various liquid biopsy sources in the patients. What do you think that decrease represents? And then the other question is if there is any thought on trying to address multiple targets in patients with glioblastoma at the same time with one CAR-T cell product.
I'm optimistically interpreting that decrease that we saw in the EGFR and the V3 is that we were targeting our intended target, and the tumor was no longer expressing as much of those proteins. And so the extracellular vesicles that were being shed by the tumor were not having as much of that RNA in it. So we were actually having an on-target effect with our CAR-T. So I think that's promising. Your second question goes back to the challenge of heterogeneity in glioblastoma. We can do a pretty good job of exerting Darwinian pressures on eliminating all the subclones with EGFR or V3, but we really need this multi-pronged attack to target the other potential driver mutations in glioblastoma. So I think all of our constructs going forward are going to have a multi-pronged approach. Or our idea was if we can turn on that local immune response within the tumor microenvironment, then we would potentially, by just having T cell go to the tumor, it would be able to turn on the immune system locally. And so that's, I think, a really promising approach to these T cells.
The last question I have is that this study has gotten a lot of well-deserved attention, and patients and families are asking their providers about this study and how it may impact their care. What would you advise clinicians tell their patients and their family members who are asking questions about this study?
It's really important at this point to re-emphasize the early nature of this work. We have a long way to go before we can make this a viable option to a larger cohort of patients. And the strict eligibility criteria required for a first-in-human study makes many patients not eligible. So we're not at a stage yet for me to comfortably say we can have a significant impact on individual patient care this time, or the majority of patients with recurrent glioblastoma at this time. And I'm hopeful, but more investigation needs to be done. We certainly have more information and contact information for our trial staff on clinicaltrials.gov, but at this point, this therapy really is just for a small subset of patients with recurrent glioblastoma.
Thank you so much again for talking to me today. I really enjoyed our discussion.
Thank you very much for having me.
This is Stacey Clardy, your podcast editor. If you've enjoyed the podcast, please take a few moments to subscribe, rate, and review the Neurology Podcast through Apple Podcasts, Google Podcasts, Spotify, or wherever you listen. And remember, you can always head to neurology.org/podcast for our full list of past episodes. Or you can also search by keyword in your podcast app for any neurology-specific topics you want to learn about.